Hello, I'm Dr. Hunter Groninger, and I'm a palliative care physician in the United States in Washington, D.C. And today I'm going to share some thoughts with you about palliative care approaches to patients who are in the last hours of life. Here are my objectives for the time that we have today. I'm hoping that after this session that you will be able to describe some physical findings that are associated with what we might call the syndrome of imminent death. I'd like you to be able to name some common symptoms associated with the dying process. And then finally, to describe the role or roles of multidisciplinary palliative care in family support at the end of life. Here's an example case that we can use to start our conversation today. Imagine a 56-year-old woman with metastatic breast cancer who is no longer receiving any kind of anti-cancer therapies. And she is at home with her family, and her family includes a husband, a brother, and 3 children. And when you meet with the family, they describe declining physical function over recent weeks that include a decline in her activities. They might use descriptions of her being bedbound, spending most or all of her time in bed, having minimal food or water intake, and that she's occasionally hallucinating and often moaning in the bed. So imagine this, and let's start to think a little bit about what is happening here. What are we able to tell the patient and family about what's happening to her, what they might expect, what symptoms should we be looking for that we can help to manage in this setting and help to counsel the family about. And then finally, how could our entire palliative care team assist? Perhaps we're coming to this visit from the perspective of being more of a medical clinician, a physician or a nurse. How might we engage our social work support, our spiritual care support? How might we engage community aid workers and so on to really provide care to the patient and her family at this time? So I'm going to start with describing what many of us might call a syndrome of imminent death. And there are different terms that are used for this. Sometimes we talk about a situation of the last hours of life, or we might use a term actively dying. I'm going to use this term syndrome of imminent death because it may sort of encompass everything that we want to try to capture in these minutes here. And it's also a term that you may find in clinical literature that might be helpful to be aware of. So first of all, to sort of describe the syndrome of imminent death, I might think about different stages that this may take place. Perhaps early on as this syndrome is beginning to take shape for a given patient, we might see less physical activity, the patient being more bedbound, maybe some decreased oral intake, food or water. Perhaps the patient is signaling that he or she is not really interested in eating or drinking as much anymore. We may notice cognitive changes that are happening at this time, sleeping more, certainly, and there may be episodes of delirium, of waxing and waning of consciousness that we might notice, or the family might notice. Further along this trajectory, we might see even more of a decline in mental status. I use the term obtundation here to just signal just no real interaction with the surroundings or with individuals. And then very, very late in this syndrome, we might see what we colloquially might call a death rattle, which is really just a lay term for excessive pooled oral secretions. I'll talk about that when we talk about physiologic changes. A patient may experience a coma, really with no evidence of conscious interaction, may develop often on fevers, altered respiratory patterns, and even mottled extremities, changes in the skin appearances in the limbs. And this syndrome is not necessarily linear. It doesn't necessarily start in this early stage and go to the middle stage and then go to the late stage. So you may just have to do your own observations and see where the patient may be fitting in this setting, but this can give you a sense about some progression of the dying process that individuals may experience. And the time course for this can be quite variable. Sometimes we sort of think of a range over which the syndrome of imminent death might take place, maybe as short as less than 24 hours, someone that we might expect to die sometime today, or as long as 1 to 2 weeks. Again, that is a vague sense of time, but they can help us to counsel families around some number of hours to days over which this dying process may take place. I'm trying to indicate here on this slide that across the spectrum, on the shorter end of the spectrum, around less than 24 hours, maybe a couple of days, those are some of the findings underneath that we may see in these individuals. These are individuals that have been experiencing some progressive cachexia for some time. They may have an underlying progressive illness. In the case of our patient, her metastatic breast cancer, and we may hear a story about progressive functional decline. Someone who was, a few months ago was out and about and active at home and socializing and doing things with family and friends, and then over time is really becoming more and more removed from that and more focused on time in the bed, time not being physically active. And at the other end of the spectrum, we might see a longer course for this syndrome of imminent death for someone who, before the inciting event leading to the dying process, perhaps someone who was well nourished. And this might be, for example, someone who was relatively healthy, or maybe had some well-managed chronic illnesses and then experienced an acute illness or an acute trauma on top of that. That person might have a longer period of a syndrome of imminent death. So my question at the bottom, where might our patient be on the spectrum? I've given you a sense about this when I was describing the time course here. We might think of our patient in our case, perhaps a little more on the shorter end of the spectrum. Hours to days might be a prognosis that we might give the family if asked. So let's move on a little bit to think about common management strategies. How can we support the patient, and how can we support the family at this absolutely critical time in the patient's illness experience? Well, first, it's helpful to be prepared with what might be some common family concerns. And when you begin to take care of patients who are really experiencing the last hours or days of life and working with their families, you might hear some of these questions, and it's helpful to have a sense about how you might begin to respond to them. So families often want to know, is our loved one in pain? Maybe the patient is, again, not too interactive verbally, so how do we know whether the patient is comfortable or experiencing some kind of distress? Families are often very concerned about starvation. Is our loved one starving to death because he or she isn't eating and drinking the way that they used to, and we often associate eating and drinking with being healthy and recovering from illness. What should we expect in the coming time? How will we know that time is very short? For many families, this is a new experience, and when we're supporting patients and families to throughout the dying process in any care setting, but particularly at home, it's important to help counsel families about what to expect and how they can be prepared. Should I stay by the bedside? Should we stay by the bedside? Can our loved one hear what we're saying? This is a common question from families. And then finally, what do we do after death? What's the next step, especially for families who've never experienced this before? So I wanted to just give you some example responses. These are not the perfect responses for every situation. You'll have to continue to develop your palliative communication skills to assess what the families need in specific circumstances, but I wanted to at least give you some food for thought as you reflect on the concerns that I shared with you before. So when a family asks, is our loved one in pain? It's really important to reassure that our role is to work very hard to prevent this, and we can share some potential signs of physical distress or emotional distress with families, and give them a plan of what to do in those circumstances if we're not there at the bedside with them. Is our loved one starving to death? I think it's helpful to really reply with some certainty. No, they're not starving to death. This is a normal process of the body shutting down, losing appetite, losing interest in eating and drinking. And that in of itself does not signal a sense of starvation or hunger that is unmet. What should we expect? How will we know that time is very short? Again, counseling and education, that our palliative team is there to help prepare families for what may come in the coming hours and days, and we can tailor that preparation for the individual patient circumstances. Should we stay at the bedside? Sometimes I like to tell families that if it's important to you to be present at the bedside, then yes. We never really know what may come at any given minute or hour. I think it's important to remind families that the patient really cannot care for himself or herself, cannot advocate for himself or herself, and really should never be left alone in the home at this time, even if you aren't directly at the bedside all the time, to be nearby in case of something unexpected. Can our loved one hear what we're saying? It's impossible to know for sure because the patients are typically not able to communicate, but I always recommend talking to loved ones as you wish. Let them know that you're there. Let them know that they are safe and that you're caring for them. That can be a really important part of the family interactions at the end of life. And then what do we do after death? The processes may depend on the specific circumstances, if a patient is at home or in a facility or a hospital. But I think it's helpful to remind families that death in and of itself is not an emergency. That can be a very important moment for the family to be together, to be at the bedside if they wish, to grieve together. And part of our job as palliative team is to help them make a plan for what to do after their loved one dies. And then finally, I wanted to talk a little bit about the palliative care team. Again, you're learning this as an individual, but hopefully you are or you will be practicing as part of an interdisciplinary palliative care team. I really think that that's when we do our best work. So I wanted to think a little bit about how we might approach supporting patients and families in the last hours of life as a palliative care team. So remember, this is a common theme when I teach that palliative care is an interdisciplinary discipline, that we really need to bring our colleagues from other backgrounds together in order to provide the best patient and family-centered care. So in this syndrome of imminent death and care in the last hours or days of life, you might think about different domains of suffering that a patient or a family may experience throughout this course, and then work with your team to do the best that we can to alleviate those different sources of distress. So from a physical perspective, for the patient, I've talked about common symptoms that patients may experience in this final common pathway of last hours and days of life. Important that we educate family members about those signs, some of the signs of the syndrome of imminent death that I shared with you, and work together on a medical plan for managing symptoms and what medicines are available, what the family can do to alleviate any physical symptoms present. And I'll also put in a comment about deprescribing, which is a term that we often use here to signal removing medicines or medical interventions that are not important, that are not helpful to supporting a patient at this time in his or her life. So some examples that I see commonly are counseling a family to stop worrying about blood pressure medication or cholesterol medication. This is not a time when those medications are going to be helpful to make the patient more comfortable, so we can stop those. From a spiritual perspective, again, it's important that we're always assessing for existential distress. supporting prayer or the faith tradition of the patient and family. And some of that work may come in collaboration with the patient's or the family's religious leader. Often those leaders are an important part of this experience for a patient or a family. And we can work well, collaborate together to make sure that the patient and family are well supported in whatever religious tradition is important to them. Psychologically, patients certainly may be experiencing emotional distress depending on their level of consciousness. It can be challenging to assess that, but it's important to look for it and also to reassure family and help attend to their distress as well. They may be grieving the loss of their loved one in advance of the actual moment of death, and that's important for us to be aware of it, acknowledge it, and give tools and support to help them through this time. And then socially, remember that the death of a loved one signals the breakdown of a family unit, a permanent change in the family structure and how they interact. And there may be both social and financial implications of the death of this loved one. Think about someone whose role in the family is to prepare food every day. And now the family is going to have to think about a different way of attending to that task. Or this individual may be the breadwinner for the family, and this may be a really significant negative impact to lose this person, not only just for who he or she is, but the implications to the family unit at large. And it's important for us to be aware of those and develop our communication skills so we can speak to families about this. From the perspective of managing the syndrome of imminent death, I think these might be some helpful ways to start the process of managing this very complex situation. First, it's important to confirm treatment goals and make relevant adjustments. I mentioned in the previous slide that term deprescribing, stopping medications that are really not relevant to comfort, because we're really focused on how we can help the patient to be comfortable right now. And a way that I explain this to families may include phrasing like this: doing everything that really promotes the goal of comfort. That's our goal, but stopping interventions that are not helping that goal. And that can often help families to understand these important changes in a medication regimen or a treatment plan as our goals shift to focus on comfort at the end of life. Communicating clearly what's going on. I think it's really important that we communicate very supportively and kindly, but also directly. It can be very important for families to hear that the patient will not live much longer. To know in a kind and supportive way that we anticipate the patient may die very soon. That helps the family to grieve and to prepare for what's coming. Excellent mouth care and skin care is a very important part of promoting dignity at the end of life. Counseling and supporting families in terms of their own distress, and then supporting them through this potentially very unfamiliar process of caring for a loved one at the end of life. And then finally, treating the signs of imminent death and symptoms that may be arising along the way. To some extent, this is a common pathway that I'm sharing with you that applies to many, if not all, patients at the end of life, but everyone is a little bit different, and we have to be prepared to some extent for the unexpected. I did want to touch on common symptoms that arise during the last days of life, and when I'm working with clinicians who are learning palliative care, I often talk about these particular symptoms as something that we should all be at least incorporating into our plan of care for just about anyone who is approaching death in hours to days. Any one of these symptoms we could have an entire lecture or didactic on, so I won't be able to go into specific management strategies for each of these, and some of them will be covered in other didactics, but at least for you to be aware as you are providing care to someone who is actively dying, to be making sure that part of your palliative care plan includes assessing and managing pain, dyspnea, nausea, constipation, agitation or delirium, anxiety, excessive oral secretions, and fever. It's really important that our palliative teams assess for these, have a plan, and then educate the family on how to mitigate these symptoms if we're not at the bedside when they occur. So here's my summary. We've covered a lot about the last hours of life, and I hope that you've had a sense of how you might recognize the syndrome of imminent death, the importance of interdisciplinary communication and support to the family. This is critical at this time and really helps this experience to minimize distress and to help families muster through this this critical time in the patient's life and in the family's life as well. And then finally, to recognize and plan and communicate and really have a way of managing common symptoms that may occur in the last hours of life. This is something that we as palliative clinicians can be the expert in. Thank you for your time today. If there are questions, I know that we'll discuss this in our next meeting coming up soon. I'm really grateful for your time today, and I hope this has been helpful.